Tim, another critical topic, trauma and attachment. And today we have Dr. Gary Sibcy with us. He has a PhD in clinical psychology, and he's also a practicing psychologist with the Piedmont Psychiatric Services. In addition, he's a professor of counseling at Liberty University. And Tim, I believe that he is also co-author with you of a book on attachments. Is this correct?
He is.
Okay, well, good. Could you tell us what Gary's going to talk about?
Attachment is a fascinating area of study. It really is a theory of relationships, and it's also a theory of emotion. You're going to learn that each one of us have an attachment style. It's core relational beliefs that affect or infect how we do or don't do relationships, intimacy with others. And more importantly, you're going to learn, too, that we really believe the word safety is a key component in this whole world of understanding trauma. Being safe in relationship, getting your core relational beliefs right, and then responding to people in their attachment style. That's what you're going to learn in this lecture. Gary's a great presenter. He's got a wealth of knowledge, and he's got a great heart for people. Let's go now to Dr. Gary Sibcy.
Hi, I'm Dr. Gary Sibcy, and today we're going to talk about attachment and trauma, and we want to talk about this in a broad set of context of how attachment can affect trauma, whether or not people get things like PTSD, and also about whether they, how they recover in the process of recovery, and how we want to take attachment issues and attachment beliefs into consideration when we're trying to help folks. And we also want to talk a bit about how this is relevant to a wide variety of traumas, and especially with the military and their family. Let's just start real quickly with discussing attachment and what is attachment. You know, attachment is a God-built system that we're born with, that we come into the world with. It's not something that we actually learn. It's something that that God has programmed into our brains. And the best way to understand attachment is to understand what we call the attachment system. And this system has basically 5 components. Usually try to explain this to folks to understand what is going on when attachment is developing between a mother and a child. Now, what's important to realize about attachment is that it is it's a theory about not only relationships, but also a theory about affect regulation, how we learn to handle our deepest and strongest emotions. And as I explain these components to you, what I would like for you to do is to keep in mind that each of these components will play a role in our beliefs about ourselves and about other people, and whether we can rely on them and whether we can use them as secure bases in our lives. Now, the first thing the first component of the attachment system is the idea that when infants get distressed, they naturally seek closeness to their caregivers. And now, how caregivers respond to this and how they respond to a child's distress can affect their underlying beliefs about trust. The second component is that the caregiver is a secure base, or is actually a safe haven to the child. So in an interesting way, children can't really calm themselves down in early infancy. They require the caregiver to do that. And even as children grow older, they rely on their caregivers, their secure bases, to do that. So when you get calmed down by your attachment figure, this is the experience of safe haven. And this creates beliefs about the reliability of others, beliefs about intimacy, the belief that other people can actually be there for you when you need them. And then the third component has to do with the secure base phenomena. When children feel calm and secure, then they're willing to naturally go and explore the world. And you can see these in micro settings. You know, a mother in a strange room with her child. Once the child feels calm and secure and that mom's going to stay there, then the child will begin to explore the room. In other ways, as you know, when teenagers get older and they feel secure, then they're able to go off to college and go do things, knowing that if they need to, they can rely on their parents to help them. But the idea is that when you feel secure, you'll explore. Now, when you get distressed, then that turns the attachment system on, and you move back to your secure base to get recharged and to get calmed back down. Now, there's millions of these types of interactions throughout our lives, and there's probably thousands and thousands of them during infancy and early childhood. These form very core beliefs about ourselves and others, which we'll talk about in just a moment. But what we're going to do right now is just highlight something for you. The core emotions that we experience, things like anger, things like anxiety, things like grief and loss, and even the experience of happiness, joy, or peace, they're rooted in this attachment system. So, for example, whenever your secure base is threatened, whenever you think, is this person available to me or not, this tends to trigger both anxiety and anger, both in children and in adults. Sometimes adults have a hard time seeing this. I'll point out that in marriage, for example, when, if I said to my wife, look, I'll be home at 6, and gee, I don't show up till 8 or 9 o'clock, and I don't call, and I turn my cell phone off or didn't have it on, my wife is going to be pretty ticked off on the one hand and anxious on the other hand. And sometimes I kid around and tell folks she'll probably be worried and checking at the ER and asking some of the friends that she has who works over there, have you seen my husband come in? But once I come home, walk through that door, she'll probably want to send me to the ER because she's that ticked off at me. So that's motivated by the attachment system. It's important to see. Now, if you actually lose your attachment figure, then this triggers intense anxiety and intense grief. The thing to keep in mind about this grief, though, and this depression that comes when you lose an attachment figure, is that it leaves one with a sense of not wanting to move, not wanting to move on. When we lose people, from an attachment perspective, we're motivated to stay exactly where we are, just in case they return. I want you to keep that idea in mind as we talk about the experience of trauma, traumatic loss, and grief that can go on in PTSD. Now, that's a very brief introduction to attachment, just the attachment system. But the next thing that we want to look at is that we want to look at how some of the more core beliefs develop. Based on these interactions, based on your experiences with your attachment figure, you'll develop two sets of beliefs about self, beliefs about others. The beliefs about self have to do, am I worthy? Am I lovable? Am I capable of getting the love I need? And am I willing to get it? The flip side is, in terms of others, is, are other people reliable? Are they accessible? Are they trustworthy? Can I count on them? If I need them, will they respond to me? Now, these beliefs come together to form what we call your internal working model. These are basic core beliefs that you hold about self and other. And you may not actually be aware of them, and that's important to realize. In fact, you don't even become aware of them until you get emotionally charged. Now, out of these beliefs come really 4 different attachment styles, and I'll review those real briefly with you. A secure attachment is people have a fairly positive view of self and a positive view of other people. So they are comfortable with relying on other people, but they also feel like if they have to, they can handle distress and negative emotion. Now, folks with dismissing attachment or avoidant attachment tend to have an overly positive view of self. The idea is all I need is me, and an overly negative view of other people, namely other people aren't trustworthy and reliable and I can't depend on them, so I'll just depend on myself. Now, in an interesting way, this affects the way they handle their emotions. They tend to keep their emotions to themselves. They don't like to express their emotions, especially weak emotions, and they tend to be quite prone to addictive behavior as a substitute for close relationships. Preoccupied attachment is a person who has an overly negative view of themselves. I'm incapable, I'm needy, I can't handle life by myself, and an overly inflated view of others in that they feel like they need others in order to get calmed down and to handle life events. These people tend to overexpress their emotions. They tend to be overly dramatic in their expression, and they tend to overwhelm people with that. And they feel overwhelmed very easily by things like anxiety and anger and grief. And then a fourth style of attachment is known as disorganized or fearful. These folks tend to have negative views of both themselves and of other people. And from an attachment perspective, the reason we call it disorganized is that they often flip-flop between avoidance strategies, where they try to keep people at a distance, to preoccupied strategies where they become very needy, clingy, and dependent, and emotionally overwhelmed. And this often becomes very confusing to both them and to the others around them, as there's this sort of flip-flopping in strategies. And as you can see, these attachment beliefs are very closely related to how you handle and regulate negative emotion. What's very important, though we don't go into much detail here, is that the attachment experiences literally wire the brain for affect regulation. That God has set it up such that the way that your attachment figures interact with you, the coping strategies that they use to help you get calmed, to help you get soothed, actually become internalized into the brain through mirror neurons. And then as you grow older, you're able to reproduce those strategies in the absence of your caregivers. Okay, so that covers pretty much what we'll go over about attachment. And what we want to do is shift gears and go into attachment and trauma. What we're going to start with is just briefly covering what is PTSD. To give you a little idea of that, there's a whole series that we have that covers PTSD and its treatment and risk factors and resiliency and those issues. But briefly, PTSD has four major criteria. The first is what we call criteria A, event. A criteria A event is that you experience something that is life-threatening. So car accidents to rapes to burglaries, things that where you could potentially be killed, or that could be very threatening to you or dangerous to you or somebody else. In the context of war, it can be, continuous exposure to events, to experiences that are potentially life-threatening, or seeing the effects of that, seeing somebody get blown up, somebody getting shot, or even hearing of someone close to you dying. The second thing is that there's an intense emotional reaction. So a part of that criteria is not just that you're exposed to an event, but that you experience intense fear during that exposure. Now those are very important experiences for PTSD. And there's a lot of issues about, what actually counts as a criterion A event, and we won't get into all the debates about that. The folks that you deal with may have multiple exposures, not just one, and that's something to keep in mind. Some that began in early childhood that they didn't have in early adulthood, but let's say that they're in the military, and now they're in their experience to all the war-related trauma. Now, after the criterion A event, then we move into this issue of re-experiencing. So re-experiencing symptoms have to do with intrusions, flashbacks, nightmares, and intrusive recollections about an event. Now, this is an important part of PTSD, and often considered a classic symptom as people are getting flashbacks. There's just one thing to keep in mind is that there's different ways of getting flashbacks. I'll give you a couple examples. When people are having flashbacks, visual flashbacks, for example, they're not aware that they're necessarily having a memory. What they are experiencing is the event and all the emotions that go with the event as it happened at that time. So it's not like you're recalling something from what we call procedural memory, from semantic memory. It's something that you're experiencing in procedural memory, which is that your body and mind essentially confuses the past with the present. There's other type of re-experiencing. We call them conditioned emotional responses, where you may get all the emotion that you experienced at the time of the trauma, but it's completely independent of the context. So people emotionally are reacting to events emotionally as if they were in the traumatic situation. So, but they may not be having visual flashbacks. This is important to understand why PTSD can be so overwhelming to families when a member has this. So for example, somebody from military comes home and they get upset. They may even just get angry with their child or angry with their spouse for something relatively small, but what this does is it triggers an emotional response that is way too intense and way too out of context that it literally can traumatize the rest of the family. And they have no idea why this is happening. It can be over a very small thing. So keep that in mind, is those are conditioned emotional responses and sometimes what we call context reinstatement, where people are emotionally responding to situations that are completely out of context. They may be responding to their child spilling milk at the table, emotionally responding at the intensity of somebody shooting at them or being under extreme danger and having to be extremely aggressive to defend themselves. Another type of symptom, a third type, is the avoidance strategies. This is where people try not to think about, they try not to feel, they try to behaviorally avoid anything that could trigger these memories or these emotional responses. Dissociation, numbness, and hollowness are other forms of avoidance. It's important to realize that these are core symptoms of PTSD. It's not just flashbacks. It's not just the emotional stuff that we'll talk about here in a second. Sometimes it's these avoidance strategies, especially numbness and dissociation, that can be key features of the disorder. And then finally, there's what we call hyperarousal symptoms. This is the difficulty with sleep, the difficulty with concentration, the tendency to feel on edge and keyed up and tense, hypervigilant, the hyper-startle response that individuals can have with this disorder. And a lot of times it's because when they experience this trauma, it produces this incredible surge of adrenaline that their body stays on ready, on go, all the time to protect itself. Again, this has tremendous effects on families and on the individual and their relational lives, because the person can be so touchy and so explosive and so irritable. Now, those are the core symptoms of PTSD. The interesting thing is, why do people get PTSD? And this relates back to attachment for a couple reasons, and we'll get to that in a second. But one of the things to keep in mind is that simply having a criterion A event, being exposed to trauma, does not produce PTSD. The fact is that 75% of the population at some point in their life will be exposed to a criterion A event, but only 25% of those folks will actually go on to develop PTSD, which raises an interesting question. Why is that the case? We find similar things with war veterans and with some of the data coming up now with those returning from Iraq. Of those exposed to criterion A events, 25% or less go on to develop PTSD, depending on the population. Now, why is that? One of the main theories is that at the core of the vulnerability to PTSD is the issue of affect regulation. And what we find is that folks who go on to develop PTSD after experiencing a criterion A event are individuals who have vulnerabilities in their affect regulation system and their ability to use, respond, and as we say, use the secure base system to help them recover. when you have histories of attachment vulnerabilities, attachment insecurity, and affect dysregulation vulnerabilities, these things can set you up for developing PTSD later. And let's explain it a little bit more by talking about the process of natural recovery. Natural recovery has to do when people are exposed to stressful or potentially stressful or even traumatic events, there's a pathway that you tend to recover from. So for example, if I take my son out for horse riding lessons and he gets up on this horse and he falls off and it upsets him and he's scared of the horse, the worst thing to do would be to say, well, fine, we're not going to get you back on the horse, let's go. Horse riding is dangerous and we should have known better. That would reinforce his fear of horses and create a much larger problem. The natural recovery cycle would be to get him back on the horse, which is what we call re-exposure, and that exposure will activate stress, it'll activate anxiety because there's an anticipation that the problem's going to return, that you're going to fall off again and you're going to hurt. But when you re-expose them and help them stay regulated so they're not flipping out, and then there's the process of disparity. Disparity is that what he expects to happen, falling off and getting really hurt, doesn't happen. Now, if you expose somebody to something that they're afraid of and they're stressed about it, and what they're afraid of doesn't happen, then the anxiety will naturally extinguish itself. And with repeated practice, then the anxiety tends to leave almost completely. That's the natural cycle. For folks with PTSD and other anxiety disorders as well, what happens is that they're exposed to these traumas, and that re-exposure overactivates the emotional system. They can't regulate their emotions. They can't regulate their affect. As a result, they tend to not get a chance to experience the disparity because what they do is they overuse avoidance strategies. Avoidance is that they won't get back on the horse, or they won't expose themselves to the things that they think are dangerous. And as a result of the avoidance strategies, they may also use things like dissociation, where they emotionally disconnect. In other words, if I can't behaviorally stay away from something or avoid it, then emotionally I can check out. They may also use tension reduction strategies. Tension reduction strategies are ways that people try to self-soothe through addictive behaviors, through cutting, through suicide, through sexual addictions, through gambling, and drugs and alcohol. These are more extreme strategies that they use to try to calm their emotional systems. An important thing to keep in mind is that many of these addictive behaviors then create more trauma, more loss, more stress for the individual. So you get locked into this very vicious feedback loop. Now, that being the case, understanding what the natural logarithm is for getting better, this will help us understand the general pathway that effective therapy uses for helping people get better. And it doesn't matter what the therapy is, whether it's cognitive reprocessing therapy, EMDR, cognitive therapy. All of these therapies tend to have these components available to them. And let's just cover that. Those therapies use what we call titrated exposures, where you expose people to what their fears are in doses that they can actually handle. You don't want to overwhelm the person. Now, there's two kinds of things, though, that people get exposed to, and this is very important to realize when you're working with folks. There's the one of exposing people to the post-traumatic stress, the actual events that triggered the PTSD. And when that happens, of course, you get a lot of emotional activation of these conditioned emotional responses. They're very intense. As far as attachment's concerned, it's important to realize that in the process of therapy, in the process of trying to help an individual or their families, you're also going to trigger, whether you realize it or not, relational schemas. those internal working models that we talked about, the very fact that somebody would come to you, the very fact that somebody would want you to help them, and the degree to which they will allow you to help them, the manner in which they perceive your actions and what motivates you are going to be a part of their attachment system, and this is reactivated in the therapy itself. And it's very important for treaters and providers to be aware that just because you feel like you have the best intentions and do have the best intentions does not mean that those individuals whom you're treating will feel the same. So keep that in mind. Not everyone that you'll be dealing with has a secure attachment such that they believe that you can actually help them or are willing to help them. The other piece is that when you expose people to this and you're keeping them safe, and you're titrating that, is that you create disparity. It's important to realize that you're exposing them to these negative emotions and they're afraid that they're going to get completely overwhelmed by them, that they're going to fall apart, that they won't be able to stand them. And when they see that they come out the other side fine, then this creates healing. And this is done through what we call disparity, that you experience safety in the context of negative emotion. Now, what happens for people who have insecure attachment is that their attachment systems never really help them experience negative emotion properly. For those with avoidant attachment, their parents tend to shut them down and not allow them to experience the emotion. So there was rejection associated with that. And for families with preoccupied attachment, the parents became completely overwhelmed by the child's negative emotion, and so both of them were very dysregulated in the context of that. And often the parents became reliant on the child to help them with their negative feelings rather than helping the child get calmed down. And of course, in traumatic families, what you find out in traumatic families is that the caregivers are actually the source of the stress and the trauma for the child. So there's incredible fear and anxiety about using that person as a source of comfort. Now, we also, in the course of therapy, work on cognitive interventions where we help people change some of the negative thinking patterns they have about themselves. This is very important for addressing things like anger, traumatic grief reactions that you see. And by the way, the traumatic grief reactions are something that you see more commonly in military PTSD, where individuals feel overwhelmed by all the possibilities of what if I would have done this, or what if I would have seen that, or what if I would have, acted in a way to prevent this. There's a lot of guilt. And survivor's guilt. Why me? Why not me? Why them? So keep those in mind. Those interventions need to be addressed, and cognitive interventions can be quite helpful. And then we want to work on their affect regulation strategies. We have to address issues about identity. Who am I? It's important to see that trauma interferes with the ability to develop a stable sense of who am I, what I believe, what am I going to do with my life, what's the purpose, what's the direction, where do I go? There's an incredible sense of hollowness and emptiness with a lot of survivors of trauma, and this is often related to not only emotion regulation, but also the identity development. And then finally, the issue of relatedness, not just in terms of how it's played out in therapy, but also how it's played out in their families and in their closer relationships. And often there's a lot of skill building, communication, problem-solving skills, collaboration problem-solving skills that we have to teach folks with trauma on how to deal with and handle intense relational conflict. Many of these folks do not have those basic skills, so that when they run into the rather routine emotional challenges and conflict that comes in any relationship, they can get completely emotionally overwhelmed. If you remember those things that we talked about, those conditioned emotional responses, that you're reacting to wartime trauma over here when you and your spouse are arguing about how you're going to handle some detail of parenting, or in terms of how you're going to work on family chores. It sometimes overwhelms people to see that people can react in such a charged emotional way in a context that doesn't draw for it. Educating families on those type of issues is very crucial. Now, so what we mean by this is that there's, for treating trauma, is about treating attachment-related issues. Because one is that you're going to help people become a secure base to their families. You're going to help them use secure bases, their families, their spouses, their extended family, the church community. It's important for churches to realize that they are secure bases to the folks who are returning from the war, or for those who've come from family histories of trauma. The church is a secure base, and sometimes we have to honestly look at whether or not we're providing secure base types of interactions and services for our members. But the idea with secure base is that you as a therapist or you as a caregiver are providing the right kind of experience for this person in a sensitive way that helps them stay regulated on the one hand, but challenges them to move to a new level on the other. Now, as this comes to play, let's talk about it in terms of what we call the therapeutic window. We're going to relate this. Sometimes when I talk to graduate students and interns and residents, we talk about, well, what is the anatomy of a good therapy session for somebody who's been traumatized? Typically speaking, we usually do 45-minute sessions. It'd be nice if we could do 90-minute sessions, but insurance companies typically won't pay for those. But we think of the sessions be broken into to 3 segments. The first 15 minutes of a session is sort of the baseline. And what that is what is the person's emotional climate when they come into the session, sort of on a scale for that person of 0 to 10. Say they come in at a level of 3 or 4, and as we move along, we want to get to the middle part of the session where there's a fair amount of activation that's tolerable for the person, so maybe 6 or 7. So we want to raise that affect. And now this can be done by either having them talk about actual trauma, but you got to realize we can raise activation by simply talking about stress with their wife, with their kids, with work, with their anxieties and fears about going back to the war field or being redeployed. Any of those things that raise affect is fine. It's important to realize it doesn't just have to be trauma related. But the idea is that we expose them. Once we do, not only are we getting conditioned emotional responses that we had talked about, but also those relational schemas are coming to play at the same time. Namely, can you help me? Will you help me? And is this a safe place? The last part of the session is about bringing a person down and helping them move to baseline, where they came in. Okay? So the idea is that where they came in is where we want them to leave. Unless, of course, they come in at a crisis at 9 or 10. We don't really want them to leave in crisis at 9 or 10. We'd like them to be in a lower place. This therapeutic window means that we want to create enough stress, but not too much stress. We want to create a context where they can experience relatively intense negative emotion, and also have the experience of bringing these emotions down, being able to land this thing relatively safely. When that occurs, again, it creates disparity, namely the belief that you can't help me or that I'm completely vulnerable to my emotions, to now, see, I can handle this, I can deal with this. And this creates a really powerful context for overriding some of their attachment beliefs that may be insecure, teaching them a new set of skills for handling conflict or handling negative emotions, and integrating some of the, if they're talking about trauma, integrating some of the trauma memories and experiences in a way that that keeps them from being intrusive memories. They can recall them as we call that narrative memory, so that it's not emotionally overwhelming. All right. Now let's just briefly talk about how the different attachment styles can affect how people experience trauma therapy with you, and what to look for, And then we'll talk a little bit about how the attachment dynamics can play themselves out in families that you're working with who has a member with PTSD. Now, individuals with avoidant attachment are more likely to have difficulty using you as a secure base, in the sense that they'll want to deal with things, they'll want to minimize things, they'll want to deal with things personally, where they think that they should keep them in. They don't think that they should bother you with their negative feelings, and they tend to think of those negative feelings as weaknesses, and so they don't like to actually tell you how they feel. They also tend to, distrust you, and they underestimate the ability of other people to be able to help them. They also tend to rely on addictive behaviors. So folks who have avoidant attachment and PTSD are very vulnerable to using more of the tension reduction and addiction strategies that we talked about. And as far as therapy goes, you can't force them to use you as secure base. This is something that's done implicitly by you challenging them enough, but not over challenging them. And like we said, dosing your responses. You have to be willing to use really a longer term strategy with individuals so that they can learn to use you as secure base. Individuals who are preoccupied feel easily overwhelmed. They are very needy. They're very demanding. They can get really angry with you. They can be very sensitive to anything that you do that might suggest you're not paying attention or that you're not fully present. And they get overwhelmed by their emotions very easily and want you to rescue them. And so you have to be careful of how you handle those relationships. They may also over-idealize your abilities. Instead of underestimating, they may over-idealize them. And a lot of times therapists can get caught in the trap of really playing into that. And we often have people be cautious about it. And sometimes you need some good supervision to help guide your way through that. Folks with disorganized attachment, again, may give you a very inconsistent pattern of responding. They may start out very distant and rather cold and disengaged, and then within a matter of a session or two become, again, very needy, dependent, and helpless, and may surprise you and confuse you. And those are things to keep in mind about remaining stable and recognizing where this can come from. It's not usually from the trauma, say the most recent trauma for, say, folks with military PTSD. These patterns are very likely to have emerged based on past experiences and relationships. Now finally, we want to just talk a little bit about how we can understand treating families who have a member with PTSD. And so, for example, even treating the families with of military families. One of the issues that you see that's common for military families is this issue of the individual coming and going. This has everything to do with attachment dynamics. We mentioned earlier that when people leave, for whatever reason, it tends to it will activate the attachment system, and what you get is a lot of anger, a lot of anxiety, and a lot of grief, especially if it's experienced as a permanent loss. One of the interesting things that John Bowlby discovered early when he was studying families and the effects of separation on families was how children would react when mothers would go to the hospital. So back in those days when moms went to hospitals for something like TB or say even depression and had to go into the psychiatric hospital, they were gone for months. And the interesting thing is that when the mothers would come home, the expectation for the family and from the mother and from the father and even for the kids was that the kids would be super excited to see her, and there would be this huge welcome, and that the child would be interested in doing anything they could to keep mom happy and well. But what they found is that these kids became very angry and defiant and resentful, and it created a lot of difficulty for the parents because they couldn't understand why their child was behaving the way they were. Now, this is the case for military families often, is that when the veteran comes home or if they're still in active duty, the family has a hard time adjusting to him be there. There may be an initial honeymoon period, but then there's a tremendous amount of anxiety and anger and anxious anticipation about when you're going to leave again. And you need to be able to process this with families and understand that this is a natural attachment reaction and help them understand their feelings and normalize them. That their belief system is trying to gather, are you available? Are you there? Can we count on you? The fact of the matter is if you're gone for 15 months or so, you're not as emotionally available as you would be if you were there. And they're doing things to try to increase that availability, but still not the same thing. And so you have to be able to address and normalize some of those feelings. The other thing is that individuals with PTSD, as we had said before, their emotions are often very difficult for folks to understand. One of the hallmark set of emotions for PTSD is anger and irritability. So it's not just anxiety, it's just this tremendous amount of anger. And that anger itself can have a tremendous, can be actually tremendously traumatic to the families. And as we said and kind of referred to earlier, you know, if dad over-responds or mom over-responds to small stressors, right, it completely overwhelms them and they become very angry. This can actually create trauma in kids. An interesting thing is some of the data that they've looked at on the transmission of trauma over, from one generation to the next generation to the next generation. For example, Holocaust survivors and the rate of PTSD in their families is enormously high. And we're finding this to be true even for wartime vets. So we want to keep that in mind, that part of your intervention is to try to help in this area of affect regulation and also helping the families understand why this individual may be reacting the way they do. Keep in mind that children tend to take everything personally. So even when, for a child who's, 10 years of age and younger, if a parent gets really angry and upset about stubbing their toe in the garage and they're throwing a huge fit about it, parents don't realize that kids tend to think that the reason you're angry is because they did something wrong. And when the person has PTSD and is blowing up maybe 2 or 3 times a day in a very unpredictable way, and a lot of times this is very traumatic to kids because they feel like they're the cause of this. So what I've heard described in many families is, and I would point out to them, is that the children and families with an individual with PTSD are on edge because they cannot predict when this person's going to blow up and be in a bad mood and go off, in the same way that a person who's actually in combat sometimes feels when they don't know exactly when something horrible is going to happen. The other thing is that PTSD survivors struggle with a deep sense of hollowness and emptiness. This is part of the emotional numbing process. The idea is if I get overwhelmed with all my emotions, then I won't feel them. I'll turn them off. The problem is that when you turn off your negative emotions, you also tend to turn off positive emotions. So the people in the family tend to experience this person, if they're not blowing up and being angry and irritable, as being emotionally detached and disengaged. And now this is important to realize because it's experienced as coldness and as rejection. And so the family and often the spouses have a tremendous difficulty allowing themselves to re-trust this individual and to allow them back in their hearts. The idea is, I don't think I can emotionally handle it again, getting close to you, allowing you in, and then you leave me again. You leave the family again. So those are important dynamics to be able to help families talk about. Now, take in consideration that same spouse may have a history of loss, unresolved loss, and trauma herself. So now her husband coming and going can re-trigger those unresolved losses and trauma for her. So at that point, then you have two individuals in the family who may be struggling with PTSD. And then another experience that you may run into and will run into with folks who are traumatized is what we call happy phobia. And what this means is that individuals who have experienced lots of traumatic events, one of the things that their brain does is it realizes that trauma sometimes happens out of the blue when it's unexpected. When everything's going pretty well and you're feeling emotionally at peace. You're driving along and then you're joking with your buddies, you're having a good time, and then boom, there's an explosion and people are dead. What the brain does is that it equates positive emotion with vulnerability, with trauma, with the possibility that things will completely fall apart. So in an interesting way, there's a paradox. To be at peace and to be calm and to be relaxed is to be incredibly vulnerable. And so they find that they literally will sabotage moments of quietness and of peace, and they tend to be afraid of positive emotions. And sometimes you have to explore that with the individual, of allowing themselves to even experience positive, warm, loving feelings. And then those are the basic ideas of working with families, some of the basic issues that you'll run into, of dealing with and addressing the secure-based concerns within a family, and understanding that the intense emotions that families, like children, like spouses, and like the PTSD sufferer experience, can be really understood within that secure-based context. The anger, the anxiety about leaving, about returning, the grief of loss or the anticipated loss are all very important issues to address with them and to normalize them. Attachment's also helpful in your understanding of how treatment unfolds within the therapeutic context. So if you're a treatment provider, you're a therapist, keep those attachment dynamics in mind. Also keep in mind that those treatments out there that are very heavy into exposures, immediately exposing people to their traumatic events, can be very dangerous for folks, especially if they have unresolved previous trauma. And understanding that the key is a secure-based relationship that titrates those exposures and takes into consideration how to handle those attachment beliefs when they come up in therapy. So hopefully this information's been helpful to you, that you can use some of the information on attachment theory to broaden your understanding of attachment within families, within individuals that have been traumatized, and when you work with them and their families, you can address some of these concerns and understand them and help them understand them as well.